Thank you everyone for joining us today on our webinar covering the changes to MIPS for 2018. We're going to wait just a few additional moments for some other folks to join us and then we'll begin. Okay, so as we jump into the 2018 final rule, and again, the changes for this year, what we're going to do is go through some of the high-level changes. We're going to go through some of the specific changes of the performance categories, and as I mentioned, save time at the end for your questions as well. And as we get started, we do want to point out that we do share the information we're reviewing here with you today after the webinar, so you're going to get a recording of the webinar as well as the slides we go through emailed to you, so you have that as a resource to review internally and with others that you work with. What we also want to share is that you can access the handouts of the webinar through the handouts tool within the GoToWebinar pane. So if you go ahead and look there, you can click on handouts and access the actual slides we'll be going through here today. Download those, follow along there, or again, just have those for your reference. So here with you today, my name is Philip Spence. I'm a sales consultant with HealthMonix, and we also have our communication specialist, Christina Zink.
Hello.
And Christina is going to be helping out with our questions and throughout the webinar as well. As I mentioned questions, please know that we do have the questions toolbar in the GoToWebinar pane there. You can go ahead and type in your questions at any point in time. We'll be able to respond to you as you ask questions, and we'll save time to read those questions aloud and review them together so everyone can benefit from the information we review. Now, before we jump into our agenda, I do also want to share a quick poll, and we often do this to just gain a better understanding of our audience and help tailor some of the information we have to who is on the webinar with us today. So you're going to see the first of two poll questions appear on your screen. And the first is, have you started MIPS reporting for 2017? So if you could go ahead and respond there with yes or no, whichever best fits your practice or organization, we'll be able to share the response. And again, that's going to inform us as to how experienced you might already be with MIPS. I'm just going to wait one more moment for additional responses, and we'll go ahead and take a look at the results together. So the majority of attendees have already started reporting MIPS for 2017. That's great. We interpret that as you already are familiar and somewhat comfortable with the reporting requirements, so we won't take as much time reviewing what you should already know for MIPS for 2017 as we look at the transition to 2018. And our second and final poll question, what best describes your role within your organization? Again, if you could just respond with the most appropriate answer for you, this is going to adjust how we address, some of the information as we understand the approach you take will be a little different based on your role within your organization. Again, I'm just going to wait another moment for additional responses to come in, and then we'll share the results. Okay, so now I will close out the poll and share the results. And the majority of attendees are in a practice administrator role. Helpful to understand, you might be working with one or multiple clinicians, maybe in a small practice, maybe in a larger size. Also, we have some quality improvement officers and healthcare executives. You might be looking at a larger scope of eligible clinicians or maybe more intricacies within your organization, aspects of other reporting systems as well that MIPS might need to fit into. And then we have some others as well. So we'll try to hit each of those points, understanding right now, as of those responses we received, there are no clinicians with us on the webinar, so we won't go into that level of detail in some of the aspects of reporting. So thank you for your participation there. You can sit back and relax now. We'll be going through just information for you to digest and understand about MIPS in 2018. So again, we are HealthMonix. We do like to share up front, we are an organization that not only provides education and resources about reporting, we do also offer a reporting solution for MIPS and certainly MIPS in 2018 as well. But the purpose of our webinar here today is to focus on the changes. So we just want to make that clear so you know a little more about who we are and why we're bringing you this information. We feel like everyone gaining a better understanding of MIPS and the regulations is going to help the overall purpose of our organization, which is to help improve the quality of healthcare being provided. So with that in mind, we're going to dive right in. And our agenda here today, as I mentioned, we're going to look at some of the highlights, top level things that you shouldn't leave today's webinar without knowing and understanding what those changes are to the 2018 MIPS program. Then we're going to dive into the performance categories. There is a major change here that will impact the scoring, so we're going to look at what those categories are for 2018, how they're different, so you can also prepare your practice or organization for managing those differences. Then we'll look at the final scoring and the process to submit MIPS, as there are some changes as well for 2018. And we'll leave time, as I mentioned, to answer your questions at the end of the webinar. Once again, if you do have questions, go ahead, put them in the GoToWebinar toolbar as they come up. We'll respond directly to you and then discuss aloud at the end. Okay, so we're going to go ahead and get into the highlights. So what's new for 2018? I think from the biggest picture, the thing you can take away about the 2018 rule is that CMS tried to make the MIPS program easier for smaller clinicians to manage, report, and be successful with it. And I think that's a big thing we see throughout the changes for 2018, that they really value the feedback they received from many clinicians, participants, interested parties for the MIPS program, the quality payment program, that it was difficult for small practices and certainly for solo providers. So some of the changes we're going to highlight here do address how it can be easier for that population to report MIPS, and then there are a number of different exemptions we'll go into as well that can affect different types of eligible clinician groups in reporting as well. So some of the biggest changes for 2018. First, we'll point out that virtual groups are going to be a reporting option for 2018. And we'll go into that and each of these big changes in more depth a little later. But that's going to be new for 2018, really looking at allowing clinicians who are not under the same tax ID to report MIPS together, and is going to have a process that comes along with doing that. As I mentioned, there are new exemptions and considerations for small practices, again in line with what I mentioned regarding CMS really taking to heart the feedback they received that MIPS is difficult for smaller practices and finding ways to make it easier for them to participate and be successful. The automatic reweighting of the Advancing Care Information or ACI performance category for certain extreme and uncontrollable circumstances. We'll define what those circumstances are and share how that reweighting occurs. And then finally, the big piece is that cost is now going to be 10% of the final MIPS score. What we understood prior to the release of the final rule is that cost was not coming until 2019. Now it will be a part of 2018 reporting and will be 10% of the MIPS score. So something you may already be familiar with, not new for 2018, is who's going to be eligible. We like to review this so if you have a mix of clinicians within your practice, you know who's eligible and who's not from this type of clinician vantage point. So for this first grouping of clinicians, physicians, physician assistants, and so on, they have been eligible for MIPS beginning in 2017, the first year, and will continue to be eligible for MIPS, while the second grouping of clinicians, including physical and occupational therapists and psychologists and so on, does not become MIPS eligible until 2019. So this does not represent a change, but again, we want to point this out to ensure you know which of your clinicians might already be exempt from MIPS for 2018, as they do not need to report until 2019. Now, to some changes that have occurred, the eligibility exemptions have slightly changed. Still, we have the option to be exempt if you are newly enrolled in Medicare. So if you fall into that category, you would not need to report MIPS for this year. If you are faced with the low volume threshold, which would allow you to be exempt from MIPS if you are billing less than or equal to $90,000 in Medicare Part B, or billing 200 or less Medicare Part B patients, then you are considered exempt from MIPS. Now, this is an increase in the low volume threshold such that in 2017, if you billed less than or equal to $30,000 in Medicare Part B, or saw 100 or fewer Medicare Part B beneficiaries, you are considered exempt. So now that's raised and will allow a larger number of Medicare beneficiaries, or a larger number of eligible clinicians, I should say, to be considered exempt for MIPS for 2018 reporting. And finally, participation in an advanced alternative payment model will allow a clinician to be exempt from MIPS. And you should know already if you are in an advanced alternative payment model, but those types of clinicians who are in those programs are going to be exempt and have different reporting requirements for 2018. Now let's look at something else that has slightly changed, which is how you report in terms of collectively how information is being submitted to CMS. So like in 2017, clinicians have the option to participate as a group or as an individual, which really means that you can participate at an individual NPI level or across your entire tax ID. Now, with 2018, additionally, you have the option to report as a virtual group. And in just a moment, we'll go into more information about that option. Similar for 2018, you must report as a group or individually or as part of a virtual group for all performance categories. So if you do find yourself and participating as a virtual group, you must do so for all performance categories. Same thing if you're doing quality for reporting for your individual providers, then you're going to have to do your ACI and IA as individuals as well. So that just must be the same process, individual group or virtual group for each performance category. Now let's get into what are virtual groups. So the idea behind virtual groups is the opportunity to allow clinicians who might be located in different areas or parts of different tax IDs who can come together and report collectively their MIPS information to CMS. So a virtual group is a combination of 2 or more tax ID numbers who will aggregate their data to report as a group. So who can participate as a virtual group? solo practitioners, groups of 10 or fewer practitioners, so the idea here is for smaller practices, and participants must exceed the low volume threshold. So if an individual clinician is below the low volume threshold but wants to participate in MIPS, they would not be able to do so within a virtual group. Now, how you participate is a little difficult in this first year, as although you have the opportunity to participate in a virtual group in 2018, you must self-nominate to do so by December 31st of 2017. So if you're looking at the calendar, that's about a month, and that's a little time to make that decision. And from reading the final rule, what we've learned is that CMS anticipates only those who have really already engaged in reporting as part of a virtual group will do so for 2018. And if you're just learning of this option and considering it, it's likely something you would do for 2019 or in future years. If you do want to review the process or have already begun, CMS has released the Virtual Groups Toolkit, which is linked in the presentation. Again, you can access when you download the handouts of the presentation or as we send those out to you after the presentation. So now we want to talk about the second big change that we highlighted earlier, which is the ease of reporting on small practices. So small practices are defined as practices with 15 or fewer eligible clinicians. And one of the big changes is, or differences we'd like to point out, is that for quality measures where you could earn a minimum of 3 points per quality measure for MIPS in 2017, the scoring is a little different for MIPS and for quality in 2018. But small practices will still have the ability to earn a minimum of 3 points on reporting quality measures. So if a small practice does report just a few patient visits under the data completeness threshold, which really means how many of your patients who are meeting or eligible for quality measures do you need to report on. If you report below than what is expected for MIPS for 2018, small practices are still going to get 3 points. So one of the ways that it's going to be easier for them to succeed in MIPS. Bonus points are going to be added to the final MIPS scores for small practices. We'll go into that, what that bonus point value is, but again, making it easier for small practices to have a higher score. And there is $100 million dedicated to small practice assistance, education, and guidance. Again, showing the dedication CMS has put on ensuring small practices are able to participate in MIPS successfully. Now, looking toward the ACI exemption, the Advancing Care Information Exemption, another thing that CMS recognizes that there was a whole lot of clinicians and locations throughout our country affected by really catastrophic events. Highlighted here is Hurricane Harvey, Irma, and Maria. And for those clinicians affected by the hurricanes or other catastrophic events, CMS has implemented the hardship exemption for these types of situations where clinicians who were impacted can receive an automatic reweight of their ACI score of 25% of their overall MIPS score into the quality category, raising the score of that category. And what is interesting, too, is that CMS has said this is going to apply not only for 2018, but also retroactively for 2017. So if you were impacted by one of the hurricanes mentioned here or another public health emergency, you can actually contact CMS and confirm whether you are going to receive the automatic hardship exemption and the reweight of the ACI performance category. Additionally, clinicians who are using an EHR that becomes decertified, and this will also be in effect for 2018 and I believe 2017 as well, is going to allow you to receive an automatic reweight. And it's something we've already begun hearing, as we speak with clinicians, that some EHRs are becoming decertified or are shutting their doors for 2018. And if you are working with an EHR who falls into that category, again, you can receive a reweight of your ACI scoring. Now we're going to look at the changes to the performance categories within MIPS. So as we discussed earlier, or really learned through the poll questions we introduced, the majority of you have already been reporting MIPS for 2017, so you should already be familiar with what these programs are. From the big picture perspective, I'll just review that MIPS represents a joining and combining of multiple legacy programs that have existed in the past under CMS into a more streamlined program to focus on performance. So here we're going to highlight each of those legacy programs and what they now are as part of MIPS. So we have PQRS, which has become quality, meaningful use, which is now advancing care information, quality improvement, which wasn't a defined program in the past, but is now recognized as improvement activities, and the value-based modifier, which is now cost. And as we mentioned before, our previous understanding from the proposed rule of 2018 was that cost was not going to be a part of MIPS reporting until 2019. Now with the release of the final rule, we do understand that's going to be a part of 2018 scoring and will be something you need to consider as you approach MIPS for next year. So we're going to go into each performance category and look at the important pieces that you should consider as you prepare for 2018. We're going to start with quality, making up the largest amount of MIPS points that you will earn through reporting. And with the introduction of cost to the performance categories in 2018, we see a reduction in the amount of possible points that you will earn through reporting quality. So quality will still ask you to report for 6 measures, measuring certain clinical quality actions, that you are reporting also on at least one outcome measure. And if one outcome measure is not available, you report on at least one high priority measure. So that piece has not changed. Additionally, you can report on a specialty-specific measure set or subspecialty measure set, which is simply a group of measures that CMS has already put together and proposed as clinically relevant for certain specialties to consider reporting on. So big change here is the 50% as opposed to the 60% of your MIPS score for quality. Now let's look at a comparison of some other changes. So the first change we highlight is the score, once again, moving from 60% to 50%. The second piece we highlight is that the data completeness threshold, which we referenced earlier, is going to move from 50% of all payer information to 60% of all payer information. And what that means is for the measures you decide to report on, you will now report on 60% of the eligible patient visits for all payers. So that's an increase and certainly will necessitate a larger look at your workflows and your technology tools to capture that information to make sure it's easier to report on that all-payer information. Additionally, the performance period is going to change from 90 days to a full year to a full calendar year. So this is another piece that really necessitates you to look at how you are capturing your MIPS quality information, because no longer can you just report on the last 90 days of the year or any 90-day window for that matter, but beginning in January for the entire year, you should be considering how you're doing in MIPS and tracking your quality measure performance and being able to use that information to report on at least 60% of your patient visits for the measures you're reporting on. And as we talked about and touched on a little earlier, for 2017, if a clinician or group of clinicians reported on a single quality measure, you would get at least 3 points. Even if you didn't meet that 50% data completeness threshold, you'd get at least 3 points. Well, for 2018, clinicians in small practices will continue to earn 3 points for reporting on at least each quality measure, even if they're not meeting the data completeness threshold. For clinicians that are part of practices greater than 15 providers, now you will get 1 point for reporting on each measure. So if you are looking to report on really minimal information, you're not going to get as many points for reporting on just a few patient visits per measure. So if you subscribe to the thought process of one patient, one measure for 2017, really not going to be an option for 2018 because you're going to get less points, and as we review shortly, you need additional points or more points than you did in 2017 to avoid the penalty in 2018. Finally, we point out here that for topped-out measures, which were simply measures with high benchmarks, where the majority of clinicians reporting on those measures were doing pretty darn well. In 2017, they were hard to earn the highest amount of points by reporting on them because essentially you had to have 100% performance. Now they're going to have some additional restrictions to reporting on what CMS considers highly topped-out measures. And highly topped-out measures are measures that CMS has identified, labeled as highly topped-out, again, meaning that the benchmarks are so high that the majority of clinicians are meeting them very frequently. And now you are going to have your point value capped at 7 points for reporting on highly topped-out measures. So if you have reported on measures that fall into that category, you're going to receive less points by reporting on them. And certainly if you don't have perfect performance for those measures, it's going to be even harder to earn a high point value by reporting on those measures. So you might immediately ask, what are those measures? And we've got those listed for you here. So the highly topped out measures, the one that jumps out to us from this list is number 224, melanoma. And that simply from our function as a registry and helping clinicians to report, we know that's one that many clinicians have reported through our services. And the others might certainly be relevant to your practice and your providers and specialty, but these are what CMS considers to be highly topped out measures. So if you have previously or are currently reporting on one of these highly topped out measures, you may want to consider finding different measures to report on for 2018. Because once again, the better you report, the higher performance you have within the MIPS quality measures you select, the more points you will earn within MIPS, and the higher potential incentives you can earn through the MIPS program. Now we're going to transition to the Advancing Care Information Performance category. And as we mentioned earlier, there are additional reweights associated with ACI for 2018. Otherwise, there are a few changes to ACI. We'll highlight what those changes are. First, we point out that the weight of ACI for your overall MIPS score is going to remain the same at 25%. For ACI, unlike quality, you can still report on a 90-day minimum reporting period. So if you are collecting information on ACI measures, maybe you have not yet engaged your EHR or your clinicians on using a certain function of your EHR, you do have time and flexibility in finding a date range that will fit collecting the information and doing the actions for the measures you want to report on within ACI. An additional change for 2018 is regarding the ability to use not only 2014, I should say not only 2015 edition Certified Electronic Health Record Technology, but also 2014 edition. So from the 2017 MIPS final rule, so how we understood things at the beginning of the year, we anticipated that CMS would restrict the use of 2014 EHR technology when we began reporting in 2018. They've scaled back that requirement as many EHRs simply aren't ready to upgrade to the 2015 edition. So CMS must react to that and now allow additional use of 2014 EHR technology. So for those of you who are using 2015 edition technology, you're going to actually earn bonus points for using 2015 edition technology for MIPS reporting. And as has existed in the past, you do need to report on at least the base ACI measures to get any point value within the ACI performance category. Now let's look at some additional changes to ACI. So the worth or point value of the performance category will remain the same at 25%. As we just mentioned, you can use either 2014 or 2015 edition technology, but for those clinicians who use 15 edition technology, you're going to gain some additional bonus points. For 2017, you were able to report to additional public health registries and receive up to 5% bonus points. So for 2018, that's going to be more advantageous, as you'll be able to earn 10% for reporting to the first additional public health registry, or I should say the first public health registry, and 5% per additional public health registry. So this is going to, again, make it more appealing to clinicians to report to public health registries and gain more points within the performance category. In 2017, for ACI, hardships existed for hospital-based clinicians, non-physician clinicians, and non-patient-facing clinicians. Those still each exist, but in addition to that, CMS has added an exemption for clinicians in an ambulatory service center. So that group can now also receive a reweight for ACI. Also, clinicians who are using an EHR that becomes decertified or has become decertified, you can also get the reweight for ACI. And finally, for ACI, there are or were really no measure-based exclusions, and that really impacts the base measures for ACI. You had to do the base measures and have to in 2017 to get any ACI points. In 2018, the change compared to 2017 is that you do have the ability to have e-prescribing and health information exchange excluded or receive an exclusion for those particular measures as part of the base measures. And this makes reporting ACI more flexible, as we did here over the course of the past majority of 2017, that certain clinicians use EHRs that don't have the ability to e-prescribe, or they don't work with other clinicians or specialists that they can exchange information electronically with. So this makes it a little more flexible. So if there is an aspect of the base measures that you can't report, if it's e-prescribing or health information exchange, you can still potentially gain the full point value within ACI. Now we're going to move on to improvement activities. And the improvement activities are fairly similar to 2017. And we're going to highlight once again some of the changes that we've seen, really some additions to the performance category that we'll review. So we're still going to be looking at 15% of the MIPS score for reporting on improvement activities. And for improvement activities, the target will be earning 40 points. And those 40 points can be achieved by any mixture of high weight and medium weight activities, with the high weight activities being worth 20 points, medium weight activities being worth 10 points. And for those clinicians who are in a rural area or setting, in an HPSA, or are considered non-patient facing, you will only need to earn 20 points, which could be made up of 1 high weight or 2 medium weight activities, to get the full 15-point value within improvement activities. Additionally, as has existed in 2017, full credit will be awarded for patient-centered medical home models or clinicians participating in those models. So if you are in a patient-centered medical home model, you're going to get this point value and all of your points within improvement activities all automatically provided to you. So for the changes in 2017 to 2018 for improvement activities, we saw that there was an addition of multiple activities that CMS believes clinicians will be able to report on, 21 new activities that are going to be available for your consideration for reporting on. Additionally, 26 of the current activities have been modified to some degree. So you'll want to take a look at those as well. Hopefully, if one of the activities you're currently reporting on has been modified, it's in a way that you can continue to do that activity. This list of activities, the new activities, modified activities, is available in the final rule. certainly something that you could do as you prepare for 2018. Determine if the activities that you're currently reporting on for 2017 will continue to meet your, really focus on quality improvement within your practice, or if you should consider some different or new improvement activities. Finally, there was an additional, or there was one activity that was actually removed from the list of improvement activities for 2018, and then there are additional activities eligible for bonus points in ACI for 2018 as well. Okay, so now we're going to move on to the final performance category, which is cost. And again, cost is new for 2018. This is replacing the value-based modifier, but for this first year is really going to be a simplified version of that. So for 2018, costs will make up, as we reviewed, 10% of your MIPS score. And cost is going to be reported automatically through your administrative claims information. So this is not a piece that you will be required to report on separate of what you're already doing. By submitting your administrative claims to CMS, they will be able to determine the information they will use to assess you on your costs. And costs for this year will be reported over the course of the entire calendar year. So once again, not in consideration for just the 90-day performance period, but the full year. And benchmarks are going to come for cost from the performance year information. So we won't know the full benchmarks until after 2017, or I should say after 2018, and we understand the performance within that year. The actual score for cost is going to be the average of two measures. So the two measures are going to be the Medicare spending per beneficiary measure, or MSPB, and the total cost per capita, or total per capita cost measure. So these two measures, once again, this information will be collected automatically through your claims, and the average of your score on the two measures will determine your score within cost. If one measure does not meet the minimum case requirement, the score will be based on one measure. So there's some flexibility there as well. But again, those are the two pieces that cost will really look at in determining your point value towards your overall MIPS score within the cost performance category. Episode-based measures. So episode-based measures, if you reported value-based modifier in the past, were measures that were considered and included toward your score within value-based modifier. Now those episode-based measures are going to be retired. So CMS is going to take the opportunity to review and create and determine new episode-based measures that will actually be tracked beginning at the fall, but will not be counted toward your performance and your points within MIPS until the future. So certainly when CMS releases these new episode-based measures, it would be beneficial to understand how you're doing in those measures as you prepare for those measures to be included within cost in future years. Now we're going to go on to the MIPS final score and review the submission. As we already discussed, the scoring is going to be a little different simply based on cost now becoming a piece of the reporting puzzle. So you've got a change in how each performance category, really quality, is going to be scored because it no longer represents a 60% of your score. So as we look at the entirety of MIPS scores across the performance categories, once again, 50% for quality, 25% for advancing care information, 15% for improvement activities, and 10% for cost. So this breakdown, again, will impact how scoring is calculated for each of the performance categories. So new for the 2018 performance year is going to be some bonuses which will allow clinicians to earn more points by reporting certain aspects of MIPS. So for complex patients, those types of clinicians who are supporting complex patients, you can earn up to 5 bonus points toward your MIPS final score. Additionally, for practices that are considered small practices, which is your 15 or less eligible clinicians, you're going to get a 5-point bonus automatically added to your final score. For improvement bonuses, there is going to be a quality bonus of up to 10 bonus points, and this is really looking at how you improve over time in your quality. And additionally, the cost improvement bonus, which will look at how you improve the cost of your 2 measures that are being looked at over the course of the year, and you can gain up to 1 bonus point for the cost improvement. Now, this next piece is going to be really impactful as we look at how your scoring will impact your potential incentives. So immediately you'll note that this first transition pacing option is going to be that it's really raised. The amount of points you need to earn within MIPS to avoid a penalty has jumped from 3 points to 15 points. So no longer can you just do 1 quality measure or even the 1 patient and 1 measure to avoid the penalty for 2018. So if you gain less than 15 points within MIPS, you will receive a 5% negative adjustment or penalty in your Medicare reimbursements in the adjustment year, which is 2 years later. So for 2018, it would be 2020. And you can think about, how that scoring will play out. If you're reporting on just quality measures, it might not be as simple. It won't be as simple as, here's how many measures you need to report on to avoid the penalty, because unless you're in a small practice, you're only going to get 1 point for minimal reporting in any quality measure. So you really have to think about your performance within those measures. If you're if you're a part of a small practice, if you're earning that 3 points for minimal reporting, or if you really want to avoid the penalty, reporting on enough information that will allow you to gain some score above 3 points in each of the measures you report, and reporting on multiple measures. To avoid the penalty, you need 15 points. So you might think and come to the conclusion that you can avoid the penalty just by reporting on improvement activities. And if you do report fully in improvement activities, it's worth 15% of your MIPS score, which would be 15 points. Alternatively, if you report on advancing care information and get over half of the points within the category, up to 15, then or at least 15, then you can avoid the penalty as well. Now, for any point value above 15 points up to 69 points, you will once again be eligible for some incentives. And these incentives, like in the past, are going to be determined by how everyone who is reporting MIPS fares and what their scores are and how much is available to be paid out in incentives. But if you report and use quality, we use quality, for example, as you're going to gain the largest amount of points from quality. If you're reporting on 6 quality measures, you should be able to avoid the penalty by having some level of positive performance within each of the different quality measures. And finally, clinicians who are scoring between 70 and 100 points will be eligible for the 5% positive adjustment, which is the highest adjustment for MIPS reporting, as well as additional exceptional performance bonuses, which we'll look at in just a moment. And once again, if you want to earn that highest level of reporting, you should be reporting on all 4 performance categories, knowing that cost is going to be reported automatically for you. And like in years past, or in the 2017 reporting year, the impact to your Medicare reimbursements will occur 2 years later. So for 2018 reporting, it will impact your Medicare reimbursements in 2020 with either a negative adjustment of 5%, some small incentive or some amount of incentive that's positive, positive adjustment, up to the 5% positive adjustment, or you may receive the up to 3 times scaling factor and 10% additional exceptional performance bonus. So once again, these pieces are going to take into consideration how other MIPS clinicians do to determine how much will be paid out based on your performance. We highlight here as well that the payment adjustment for MIPS will follow the practice, or I should say will follow the clinician as they move from practice to practice. So understanding how that might impact your practice or organization, or any clinicians leaving your organization will be critical. And finally here, there are going to be MIPS scores posted to the Physician Compare website. So really the beneficiaries will be able to view and compare you against your peers to understand how well you and your clinicians that you work with are doing in certain quality metrics. Data submission options. So for 2018, much like 2017, there's a range of different data submission options or ways to supply your MIPS information to CMS. So starting with attestation will not be an option for quality reporting, but will still exist for ACI and improvement activities. For the QCDR reporting or Qualified Clinical Data Registry, as well as Qualified Registry, which is we are as Healthmatics, and EHR reporting, each will be able to report on all three performance categories, quality, ACI, and improvement activities. Each might have differing number of quality measures available or ability to report on certain ACI measures based on what information your EHR has collected, but all have the opportunity to report on each performance category. Claims is going to be just for individuals reporting on quality. CMS web interface is going to be available for all three performance categories for groups, and then capture MIPS surveys is going to be an option just for group reporting for quality measures. So reporting a performance category through more than one submission mechanism will not be allowed for 2018. You might ask, why are we saying this? Why are we highlighting this if we can't do it? Well, there was conversation within the proposed rule to allow clinicians to report for performance categories through different submission methods. And that's going to be coming in 2019. So that will allow you to essentially split one performance category across multiple data submission options. Might make it more flexible for you to choose how you approach each performance category and what tools you use to submit that data to CMS. So that's going to be something to keep in mind as you transition not only into 2018 but also 2019. All right, so we have gone through a lot of information with you here today, and we have reached that point in time. We do want to open up the rest of our conversation to answer your questions. So there have been some questions that have already been asked, but what we want to do is just take a few moments to allow additional questions to be entered into the GoToWebinar tool in the questions area. We'll be able to read those questions and then discuss aloud. So we're going to just take a brief moment to review some of the questions that already have been asked, and then we'll be able to review with you and respond aloud. All right, so thank you all for your patience there. We've got just a few questions so far, so keep on adding questions. We'll be able to discuss them with you. The first is, can you define a complex patient? A complex patient is determined by the average, let's see if I can get this right, HCC risk score, which is hierarchical complex category, and that's going to be looking at, really the risk that is taken by a certain type of patient, what their score is, and their dual eligibility ratio. So for that type of patient, they should be predefined as complex, and that's going to be what allows you to gain a bonus points by providing care for those considered as complex patients. We had an additional question. When you say 60% of all payers, what type of payers do you mean? Is this going to be reported for payers other than Medicare? And that is correct. So the all payers is going to be, simply put, all payers. So your commercial payers, your private payers, Medicare, Medicaid, all sources of payers are going to be included within MIPS reporting. And the reasoning behind this is CMS has said, although they're only going to receive claims based off of your Medicare billing, they do want to understand the level of and quality of performance or quality of care being provided for all types of payers. And when we look at kind of the big picture of value-based care, there are other payers, insurances and commercial payers who are looking at adopting similar models and levels of reporting. So as those other entities look at streamlining, the reporting process for providers, I think it's going to be a good step to just collect information for all payers and report it, knowing you might need to report that information to other sources in the future. And certainly one consideration is if you have a majority of your patients, under Medicare, then maybe you're just reporting Medicare and you don't need to report on other payers. That's going to be on a practice-by-practice basis, but still it's going to be important to be able to collect information for all payers and report to CMS, knowing that they might only need to or might only be able to validate the information they receive that's sent through Medicare claims.
I also just wanted to add a little bit of flavor text to Phil's answer here. So this year we attended the MACRA Summit, and we had the opportunity to hear some private payers speak about their plans for value-based payment models in the future. And all of your information, all your MIPS scores for each performance category will be publicly posted if they meet, the validity standards to Physicians Compare's database, and that is all downloadable. And what we learned at the summit is that people are absolutely interested in downloading that information. So where there might not be a coherent plan right now at this very moment for what private payers are going to do with that information, it is worth considering that they are interested in looking into that information, and it might affect you in the future.
All right, thanks for that addition, Christina. And another question here, for 2017, our reporting method has been via claims. Is this going to be sufficient for this year's reporting? So the answer is yes. You can succeed within MIPS by reporting on or reporting through claims. Now, what's going to be important to look at is, what information are you reporting, and how confident are you that what you report is meeting the reporting requirements? Because the low, the minimum to avoid the penalty has increased. If you're unsure if you're meeting all of the necessary pieces of reporting through your claims, then you might want to consider reporting through a different data submission method. But if you're confident that you are reporting fully, it might be taking a look at your feedback report when available for 2017, or if you already have your feedback report for previous year's reporting of PQRS or other programs, to understand how well you're doing, and that's going to help you determine, if claims is going to be sufficient for your practice for 2018. Okay, is the data completeness being determined by the claims sent? So great question. So the data completeness, again, that for quality is 60% of your eligible patient visits per measure. That is not going to be automatically checked by CMS against what has been sent by claims. So there's a little bit of, honor rule here that when you do report, and particularly when you do report for all payer information, that you're reporting enough to meet that data completeness threshold. And an important distinction I may not have made earlier is that if you are reporting via claims, you're reporting just by claims. You don't need to report on all payer data if you're doing claims reporting. And if that is the case, you do want to report on all patient visits to meet a higher volume or data completeness threshold specific to claims-based reporting. If you're not doing claims-based reporting, if you're reporting through a registry or EHR or QCR or different method, then you're going to want to report all payer data, and you're going to want to look at your records to determine what that data completeness threshold is to make sure that you're reporting above that. Another question, we submit most of quality measures through claims, but some measures cannot be submitted through claims. What should we do? So you've got an option here. If you are just looking to avoid the penalty, you can certainly continue to submit the quality measures you have through claims if you believe your performance will be high enough to avoid the penalty. If not, you would want to consider reporting through a different data submission option. So we, as a registry, have over 240 quality measures that can be reported through us. EHRs, each EHR might have a different number of eligible measures to report, but we'll also have a larger number of measures available to be reported through the EHR directly. And for 2018, you are not able to split the reporting for one performance category, so you can't or you cannot do some measures through claims, some through EHR, or some through registry. You have to choose one. And that, again, I think is going to come back to, are you just looking to avoid the penalty, and can you do that through claims? Or if you want confidence in reporting and want to be eligible for incentives, you should consider a different reporting method that will meet that ability to be confident and report on measures that are going to be more relevant and let you earn a penalty, or let you earn an incentive. Okay, we are a pain specialty and our provider is very limited to measures. Any suggestions? So certainly we do have measures and measure recommendations by specialty listed on our website. So we'll provide you with that link directly. But on our MIPS Pro website, mipspro.com, you can look at our quality measures broken down by specialty. And I think that's going to be a great place to start. Certainly, we anticipate changes to some quality measures once CMS releases the quality measure specifications. They have not released those yet, so there might be some slight changes to measure details. But if you have a general sense of what measures your provider can report, I think it's looking at what are, if any additional measures that might be applicable, whether that's the same data submission method you've already been reporting on through registry reporting or some other method, and what might be relevant and similar to those measures. Or it might be that you look at how you do well in the other performance categories to gain enough additional points to potentially be eligible for incentives. Okay, just going to answer a few more quickly. There's a clarification that one of the participants on the webinar was using claims and registry reporting for this year. If you did that, if you are reporting through claims and registry, CMS will simply take the best set of data. So they're going to look at the claims data independently, look at what your score is there, then they're going to look at your registry data, look at what your score is there, and pick the best submission. So they won't necessarily mix and match. They're just going to pick the best one. Will ACI still be reported like meaningful use in the past, manually on the website for 2017 and 2018? You do have the ability to attest through the CMS website directly for ACI, so that still will be an option for 2017 and 2018. Additionally, you do have options through other data submission methods as well. And then finally, do you have any idea when these measure changes will be released? So they are going to be, so actually I get a good clarification from Christina. They are in the final rule, but if you've ever opened the final rule, you know it is difficult to navigate. But what CMS has done in past years, certainly with MIPS in 2017 and past years with PQRS, is they release the specifications that's in a more portable and digestible format that can be used by organizations like us, by individuals, by groups. So that's something you can reference more easily. So you can reference the final rule and find that detail, but otherwise we will be updating our resources as we go through those measure specifications and also as we receive the measure specifications in the easier to use format. So we have reached the end of our time here. We do want to thank you so much for joining us, investing time and learning more about MIPS for 2018. As we mentioned, this webinar session is being recorded. You will receive a recording of the webinar following the close of our time here today, as well as the webinar slides. Although I didn't get to really spend time on these slides, there were 2 additional slides simply showing ways to provide feedback on the final rule. So if you'd like to do so, you can reference this when we send out the slides from today's presentation. And then also there are additional resources that we have, again, will be linked up in the slides from the presentation here today that you can reference for more information as you prepare to report MIPS in 2018. So if you do have questions about 2018, we're unable to have them addressed or they come up later, please email us at webinars@healthmonics.com. We'll be able to get back to you, provide additional information and insight. And if you're still reporting on 2017 and may consider registry reporting, we're happy to help out. Just reach out. We'll be happy to talk through your process and strategy for reporting and see how we can help. So once again, thank you for joining us here today, and we hope to have continued conversations with you all as we prepare for reporting MIPS in 2018.